Yeah, so again, we are live. Thank you so much for joining us. This is our Minority Health Summit here on blackdoctor.org, and we have had a whirlwind of programs today. We started today with colorectal cancer and talking about all of the screenings and getting colonoscopies, and we even showed you something about a special way that you can test on your own in home. I'm not going to spoil it, so you got to watch the program and share it with a friend to figure out how you can test at home to see if something's going on with your colon. Then we just got off of a wonderful program about diabetes and the unseen consequences of diabetes. We talked about diabetic retinopathy. We talked about diabetic neuropathy. We talked about unnecessary amputations. We talked about chronic kidney disease. And all of those things are connected to diabetes. And we know diabetes disproportionately impacts our community. Diabetes and hypertension, we know those are two, and they're silent killers. Learn so much about the kidneys and how it's just been a wonderful, wonderful day. So go back and watch those programs. But this program today, this one right here that we're dealing with, is something we're going to shift gears a little bit, because before those other three programs talked about specific illnesses. What we're going to talk about is how we can improve our health outcomes. And one of the ways we can improve our health outcomes is by participating in clinical trials. And I know those are dirty words when we're talking to Black folks, because we have all of these things. So we've got Dr. Lucilla Adams Campbell here with us to help us tease through clinical trials, what they are, what they aren't, what safeguards are in place, and why should Black people be more involved. Specifically, why should Black people be more involved in clinical trials and the importance it is to improving our health outcomes. But before we get to that discussion, I have a short video that we're going to play here that really kind of breaks down what clinical trials are. And we're going to do the overview, and then we're going to come back with Dr. Adams Campbell and break it down and why it's important for Black folks.
The clinical trial journey is how a medical intervention, such as a drug, device, or procedure, moves from an idea into patient care. The beginning of the journey starts with discovery science. In the lab, researchers use computers, cells, and animal models to answer basic questions like, how does DNA work? And how do cells talk to each other? After a great deal of work, this effort is ready to be translated into clinical research. This is the first translational moment. As they move into phase 1 clinical trials, researchers begin looking for answers with the help of volunteers. Here, researchers answer questions about safety and how well participants tolerate the medical intervention. These trials don't include many volunteers, and they are short, usually only a few months long. With information collected in phase 1, they move to the next phase. In phase 2 clinical trials, researchers ask, is what I'm studying effective for patients with this health condition? Are there any side effects? How does it compare to a placebo? Phase 2 trials are usually done with a medium-sized group of volunteers. The studies can last for several months to years. Now, the thing is, it is common for phase 1 or 2 trials to dead end here. Funding disappears, results are inconclusive, the intervention fails. When that happens, researchers go back to the drawing board and try again. But when it does work, researchers go to phase 3 clinical trials. In this phase, they set out to confirm the results of previous trials in a larger study. They ask questions like, how does it compare to other treatments? How effective is it with a lot more people? Phase 3 trials need years to complete. Beyond phase 3, U.S. Food and Drug Administration approval is the next critical stage. The FDA reviews all the trial data, taking into account the intervention's intended use. It must decide if the benefits outweigh the risks. Once an intervention gets approval, it is ready to become a treatment for patients. FDA approval means the clinical trials journey has reached the second translational moment. The intervention is no longer a science experiment. But the journey doesn't end there. As it's used by more and more people, monitoring ensures the treatment is still safe and effective.
Okay, so that was a brief overview of clinical trials, kind of broken down to the to the bare bones. And we've got our other guest, Dr. Jihad El Bayoubi. Hi, Dr. Gigi.
Hi,
Hi,
good
how's
afternoon. So
how about
glad to see you, and thank you, Dr. Adams Campbell, for joining us. This is wonderful.
good seeing you again. It's been a while.
I know, right?
So, Dr. Campbell, I want to ask you the first question. We know that health equity, that's like the hot topic right now. We've been hearing that term. We've been hearing that all over everywhere. Every time we turn on TV and talk about health, it's all about health equity. What role does clinical trial participation play in kind of helping close that health equity gap?
That's a tough question. Let's be realistic. Only about 5% of all, I'll focus on cancer for a minute because that's my most known entity. Only about 5% of all patients that have cancer go on to a clinical trial. It's just that less than that, much less than that, of people of color actually engage in clinical trials. When we talk about health equity, first understand how it emerges. It's health disparities that has shown the gaps. And now we're trying to bring people to par to be equitable across all race, ethnic groups, gender, everything. And so health equity is a hot topic, but oftentimes we're not there. We use that word very loosely and very lightly, I believe, because if everything was equitable, we wouldn't be talking about it in this way. But when we talk about clinical trials, I just think it's important to note that we're talking about trying to get people engaged in not experimental testing something that has never been tested before, the typical clinical trial. We're trying to get people to seek the care that's standard of care or better. And I think that's the point that's missed. And so people are calling, a person gets sick, gets diagnosed. There are people, particularly whites, that call all around finding out where can I seek a clinical trial? Because you're offered more attention, more rigor, you're offered the best that they have out there. But at best, or the worst, you're only compared to the standard of care. You're not given a placebo. I think people get mixed up. Like, if I go on a clinical trial, I'm either going to get the drug or I'm not going to get the drug. And that's not it. So it's a hot topic, but it's a hot topic for the wrong reasons. We all just need to have the opportunity to receive the best treatments that are out there. Everybody. And people shy away from it, but that's the bottom line. If I have a disease, I'm going to call and find out what's going on and what everybody else is running to. And people have to be careful when you notice that people really want to be on this clinical trial, but you don't. I don't have a trust in them. I don't want to be on it. You have to really stop and think about that statement. Why is everybody else running, trying to do well? And when we think about people of color, particularly Blacks, you look at the data, look at the burden of the disease, who it disproportionately impacts. We can't improve upon that until we become part of the solution, not the problem, but part of the solution. And the things that we find out as we go through treatments, clinical trials, we can pass it on to generations or to siblings or to loved ones, and we can continuously improve.
Dr. Gigi?
Well, I think that how Dr. Adams Campbell answered the question really helps to frame the discussion. I'm a bit weary and tired of hearing diversity, equity, and inclusion because I feel that lately it's just another box to tick off, and that's kind of what the fad is. And if you look at DEI, there are some initiatives, don't get me wrong, I don't want to throw out the baby with the bathwater, where there are people that are doing excellent work. But the people that do excellent work understand that health equity is about poverty, it is about racism, it is about education, it is about the quality of air that people breathe and the water they drink and the food that they eat. So these discussions cannot happen out of context. One thing about the system here in the United States, which is very clever, they dismantle a system and then they sell it back bit by bit by bit. So when we're talking about clinical trials, and I want to talk about a positive outcome for just a second, So as you know, the Rodham Institute is part of the Black Coalition Against COVID.
Mhm.
And, when we were hit with that pandemic, of course, the people that are most impacted are the ones that are always most impacted, right? People
Mhm.
of color, and especially, and as well as poor people or people who are from under resourced communities. But what the Black Coalition Against COVID did, which I think should be a model, is that we brought together all the different stakeholders, from the people, the scientists, to the clinicians, to the faith-based community, to community members that didn't necessarily have any, any affiliation, to, sanitation workers, that whole thing, to really tackle this issue. And what was so helpful, if we think about Dr. Kizzy Corbett, who was involved in actually the invention of the vaccine and was part of the research scientists that actually helped come up with the COVID vaccine, that underscores another problem. It's not just the people, and there were many more people of color that engaged in the clinical trials, which was great, right? But also, the other part of that equation is when we have Black and Brown scientists and clinicians, guess what? Outcomes improve for Black and Brown communities
Mhm.
over and over and over again. And I want to use a little bit of a different example, and that is sort of the LGBTQ community, and specifically gay men during the AIDS epidemic. One of the reasons that I so admire Dr. Fauci is when, I'm of the generation where I took care of people with AIDS. I mean, people were dying, I was pronouncing people dead. It was 100% 1-year death sentence.
Mhm.
But what happened is that a community of mostly white, upper middle class gay men was that they said to Fauci, look, you're not including us in the decision making around the clinical trials. It was ACT UP at the time. And he
Mhm.
said, you know what, you're right. And so what he did is engage them. Now, remember that, of course, LGBTQ communities are discriminated against, but the difference with this particular group is that they had education and class behind them,
Mhm.
right? So that was fine because they advocated for other members of their community. But it's because they got involved in clinical trials that from that 1 year, 100% death sentence,
Yep.
HIV is now a chronic disease.
Mhm.
So there are people who have benefited, who have been very smart about their engagement, but it is part of a collective attitude. How many LGBTQ people do you see now in leadership positions that are openly out at the table making decisions in all of the different sectors? How many people do you see taking care of patients? So it is not just one thing, it's all of these things at the same time. And the struggle, the challenge, especially for people from the African diaspora, is that there have been so many barriers that are so entrenched and so foundational to what I call the medical apartheid system. It takes a lot of intention and collective work, collaborations and consortia that can help to, break that barrier. It's a lot of work, but we've got models, and we also have the civil rights model, although that's being
Mm.
whatever, we can have a separate conversation on that.
So,
But
so Dr. Adams Campbell, I'm gonna kind of let's talk about the elephant in the room in terms of Black participation in clinical trials, and that is Tuskegee. Right? We hear that, we heard that when COVID was coming out, that got resurfaced. But I remember learning about it when I was in college, 1,000 years ago, when I was in college, and they would say, oh, we would talk about the Tuskegee experiment, and that's what it was called, the Tuskegee Experiment, and it was kind of boiled down. And I got a really, really unclear version of it, but I just knew that there was some black at bare minimum. There was a black man at Tuskegee, Alabama, had syphilis, and the version I got was the government gave it to him, and then just watched the results. Now, how much of a role does that play? Do you think does that play in Black Americans' perception of clinical trials? And do you think there is a way to overcome that perception?
I probably be on the other side of the coin. I'm going to say that I've been doing clinical trials and I lead the clinical trials program at Georgetown. And I don't hear about Tuskegee. And
Okay.
because there are younger people that are developing cancer, they're not in that cohort that feeds off of Tuskegee. I have never been involved in with people that say, I don't want to do it because of Tuskegee. There might be other barriers, transportation, baby, childcare, other things. And I think it's outstanding that we know our history,
Mhm.
but we also need to move forward. And I think that when we get stuck, I mean, I've heard many white doctors will say they didn't want to participate because of Tuskegee. And I've run to somebody and say, what did you say? Why didn't you want to participate? Nobody asked me. So we
Mhm.
also have it used as a way of saying and showing the bias. It's not unconscious bias, it's explicit. What
Exactly.
it's explicit bias. It's really just discrimination and not Tuskegee. So we've lived that history. We know it and we keep it in the back of our minds, but we also know the regulatory activities that have changed. We know how the procedures have changed, and we know that we protect our patients from different things regarding clinical trials. So I will not let Tuskegee be a part of the study. And I used to be the director of Howard University Cancer Center. I think when I met Dr. Chichi, I was director at Howard University Cancer Center, and we opened clinical trials there. And at Georgetown, we opened clinical trials. But what's really important is the education.
Mm. Okay.
It's like you're not going to dance at the party if you're not invited. If
Okay.
you're not told about what the study is about, if you're not really explaining the details about what a clinical trial is. And most people think you can only participate in a clinical trial if you have a disease,
Mhm.
just a disease. Well, they're prevention trials. There's a big study out called TMIS, which is really 2D versus 3D mammography screening. Women over the age of 40 have to get screened. Why not participate in a clinical trial? I joined that clinical trial mainly to show that it's a study that's natural. There are different studies that are out there that you might want to participate in. I want to be part of the solution. I want to participate in clinical trials and show that when we don't have too few people to count. You know, when people get in studies, if one black person or two black and brown people go into studies, you'll never have definitive data to talk about were there really adverse events in that group, were there really this or that. You need the numbers. So I participated in a clinical trial. It was a natural one, but there are people who do have diseases and end up with things such as peripheral neuropathy, little tingling in the fingers, or lymphedema from breast cancer, different things, pain management. There are clinical trials across the whole spectrum. And I think that's one thing people have no idea about. There's smoking cessation trials. There are many ways to participate in clinical trials, and it's not what people view as a death sentence. There are
Mhm.
things that help prevent you from getting diseases. I can tell you, all the risk factors for cancer are the risk factors for stroke and heart disease and everything, you know, all the other chronic diseases. You know,
Right.
so I think people need to be shown the whole gamut of clinical trials. And they might say, oh, I smoke. Maybe I should do a smoking cessation trial so I could stop smoking. That doesn't sound horrible. Sounds like you participate and provide data, but they also will help improve their quality of life. And they get more hands-on attention. When you're in the clinical trial, the nurse practitioner or the doctor or the research team, they're reaching out to you. They are finding out, are you having problems? Are you having barriers? Are you having adverse events?
Right.
You get more attention. You don't get that otherwise. See you in 3 months. See you in 3 weeks. But you have more attention. And I think that people can actually help you be successful in your outcome. And the biggest outcome to me is reducing mortality when we talk about people who have disease, or trying to reduce or mitigate the incidence, the number of newly diagnosed diseases, and reduce symptoms that we see associated with diseases. So Tuskegee, no.
Okay.
Today, yes.
All right. We'll put that to bed. Thank you for that. Dr. Gigi, Dr. Adams Campbell brought up an interesting point, and she's talking about really.
She's brought up a lot of interesting points, Ms. I mean, I actually have a list of 4 things to talk about because she, no, truly, people don't realize how fortunate we are to have Dr. Adams Campbell, because she is really one of the people in the field that is helping to advance the field of cancer and care for people, to make sure that people get the best treatment. And I've discussed my own 2 cancer diagnoses, one 17 years ago, breast cancer, and one kidney cancer that was just during COVID, but I made it. And I'm in a clinical trial. I'm cancer-free, thank God, after my chemo and the right kidney was removed. But I elected to participate in a clinical trial at NIH that they're just monitoring me. I'm not getting any treatment. They're just monitoring me. Guess what? When I go to NIH, I call it the spa day. I swear to God, I am not kidding. I am excited to go. I go every 3 months. And the reason I'm excited to go is I'm treated very, very well. Everything is done on one day. I actually find out the results of my scan the same day. And guess what? There is not one bill, not one penny that I have to pay. And it's like, wow. And not only that, they keep testing my blood whenever there's a new development, so that if God forbid a million times I get cancer, okay, again, or it relapses, there may be treatments. Or even if I don't, they may find that there's a certain marker in my blood that predicts cancer. So they can say, okay, you look like you're at higher risk for recurrence. Here's another trial, or here's a treatment that you can get. But so, I mean, I'm a big proponent. And so I think when you're speaking as a physician, the best way to endorse it is if you yourself are participating in. And what I always tell people and patients, I would never recommend something that I wouldn't do for myself or recommend for my family. And I think, you know, not to say that white physicians or clinicians don't do that, because there are some wonderful people, but I think it's different. And my patients will ask, what would you do for yourself? And I can say that, and that trust and that bond is so strong. But I wanted to just pick up on a couple of things that that were mentioned by Dr. Adams Campbell. They did actually a study at GW, which I credit them for, to look at Black women versus white women being offered genetic testing. Same thing. They were told, oh, they refused. They were never offered it. And so when they went back and asked those women, 90-something% said yes. Actually, it was higher than the white women. And of course, genetic testing is so important, because with things like triple negative breast cancer and all and these women were asymptomatic. They did not have symptoms. And that has implications for not just their girl children, but their boy children as well. All right.
So what do you think that
and
is?
then just I just want to add one more thing. I know I can talk a lot, but the reason, but also, why is it that this is important? So I'm going to give an example. Dr. Adams Campbell was at Howard. Dr. Chapman, who does a lot of work and cares for people who are have substance abuse issues, was noticing that the people he was taking care of, all African American, were not responding to the medication in the same way that the white counterparts did. So along with the School of Pharmacy at Howard, what he did is he started to study the pharmacokinetics. What does that mean? It means how quickly people use the drug. And guess what? It turns out that African Americans, they metabolize the medication more quickly. So that means that they actually need a higher dose. So then that meant that policy with insurance companies, they had to make sure to give a higher dose. And guess what? People that were labeled as relapsing were actually not relapsing. They never got the right dose in the first place. So that's a very concrete example of the importance of clinical trials, because for the majority of things, there are no differences between white and blacks in terms of treatments. But you know what? There may be, and we just have no clue.
You know, can I just add on to what you're saying? As you hear, people have been hearing about precision medicine. You can't get any more precise until you really delve down and look at and examine through genetic testing what their DNA composition is, what their other biomarkers are. That's how we really figure out what's really, really going on. And I think that genetic testing is what we're doing at Georgetown is offering it more and more to women and women right now for breast cancer, and they've never heard about it. So we have to educate that community about genetic testing and how it's being used. But it's in their to their best advantage to be tested to find out exactly what will be the best treatment for you, what we should be moving towards. And I think everybody would understand that better if they realize that precision medicine is where we need to go. What's good for you might not be good for you. And that's what we're showing. And analogous to what you just showed about Dr. Chapman, smoking. Blacks tend to inhale more, but they metabolize nicotine slower. So if you look at some of the genotypes and SNPs and all these genetic markers, you find out maybe this person would benefit from this treatment and this intervention where somebody else wouldn't. So precision medicine is really where we have to go. And we need everybody, people, black, brown, everybody participate. Because if everything is done on white population and then you put it in black and it doesn't work, we fail. No, we didn't fail. You failed. We weren't included. But it's our duty to be included. And I think of, as you started off, Dr. Gigi, with diversity, engagement, and inclusion, that that's like a three-letter bad word to me. Because there are too many other stamps. You know, we found one. That's not what it is. And there are people that do a great job and have been doing it. And as I tell people, I've been studying health disparities before it was popular. I did my training when nobody else was really focused on it. But then the money came out, everybody jumped on it. So you have to be careful.
Right.
Yes. And can I say something about the cigarettes too? Because another aspect is how marketing of cigarettes to Black people in particular. Remember the cool and the Marlboro, yeah. No, but the ones with menthol. The ones with menthol. You inhale more deeply when you're smoking mentholated cigarettes. And those were basically marketed almost exclusively to Black people. So why was that? I mean, there's so many aspects of this when you're trying to unravel it. And I think
the rabbit already gone. You already started. You know, it's funny, like you're bringing up something kind of personal for me in this space, because when I was, applying for graduate school, and I went and interviewed for some PhD programs, and I'm not going to say the names of the schools, but one of the schools that I went to interview, when I told them what I wanted my area of study to be, and it was going to be specifically around Black children and the development of self-esteem, and I was going to kind of, my thought was the parallel of learning about your history is going to result in an improvement in self-esteem, which is going to result in an increase in overall quality of life, improved incomes, outcomes, family, whatever, all that stuff. And they looked me in my face and said, I don't think we have a professor that we can pair with you. And mind you, they had a whole child psych program. This particular school had a program specifically for child psychology, but did not have anybody that was studying that aspect of how self-esteem is tied directly to having a true understanding of self, right? And history. And so when you're talking about inclusion, I know we said DEI is kind of a dirty word, but when we're talking about that inclusive part of it and understanding that we cannot be continually compared to the mainstream model and then say how we're defective because we don't meet that model. And we got to define it for ourselves.
And then let me come back to that mainstream model. So my dear friend, Dr. Crystal Dixon, who's at the University of North Carolina, Greensboro, has been involved in a study looking at improving outcomes of both lung cancer and breast cancer for Black women. Guess what happened? White women's outcomes improved too. Because there are problems with the system overall that disproportionately impact people of color, right?
Right.
But that there are other benefits, right? Like the civil rights movement. Who did it benefit? White women,
The most, yeah.
for example.
Yep. And also, you're talking about a few things, role models,
Mhm.
not enough, but also, I wish you had pursued that PhD in that program and you started. See, that's the other thing. People have to get the grounding, the training for the PhD, the advanced degrees and all, but then you veer off. When I went to the University of Pittsburgh, I was it. So when I went there, my focus wasn't on anything that anybody was doing, but you learn the tools, you learn what you need to know, the depth of knowledge you need. And then that's the beauty and the beast of being so few in a field. You get to carve out a niche that you really hone in on and you master and you understand. So just because something is not there,
Yeah.
all the tools and elements and the education and all the didactics are there. You just have to then elevate. And networking is so important. You maybe at those institutions there was no one, but there in the country are people that eventually will start networking and connecting the dots and still grow and expand, even in an environment where it never existed. So I'm always attuned to that, and you have to make certain, carve out your niche and decide this is what you're going to do, but you have to take the path to get there.
Can I bring up a mentor who recently passed? He was the one that actually interviewed me for medical school at University of Michigan, and that is Dr. O.T. Randall, who was a pioneer in hypertension. He did research in this field and really helped advance, our ideas and how we treat high blood pressure. Dr. O.T. Randall, and I had the fortune actually of seeing him a few years before he died as part of a reunion for African American physicians. He and a group across the country, now mind you, I went to medical school, I started in 1981, made a deliberate and intentional program to bring more really people of African descent into medical schools.
Mm.
So in my class, we had about 35 people. The majority were men.
Mhm.
So we had actually a higher thing. So the other aspect of this, because being the only is very difficult. I was a member of the Black Medical Students Association at University of Michigan, and guess what? We're still together.
Mm.
And we're honoring another wonderful faculty member, the late Dr. Ralph Gibson. These pioneers also had the political and philosophical idea that really is informed by the civil rights movement, that these were important issues. He was a clinician, researcher, mentor, but also an activist and advocate. So there's also this other idea of responsibility of paying it forward and making sure that we don't get tokenized. I mean, how often, Dr. Adams Campbell, have you been told, oh, you're so wonderful, and so
Yeah.
this and that. And
Then I say no.
and no, what I say is this: I am one of tens of thousands, if not millions. I appreciate the comment that I'm special, but I'm not that special, right?
Well, Dr. Gigi, let me just say, in 1990, Dr. Otilio S. Randall hired me at Howard.
Wow. See? Small. I love that. I loved him.
That's how I got to Howard. I was in cardiology.
Wow. Wow. See, there you go. It's a small world.
So if you're just joining us, or if you're joining, because there's people watching us from around the world. I think I saw South Africa earlier. I got somebody's watching us from Iraq. So thank you all for joining us. We are talking about clinical trials, right? We're talking about the future of medicine for Black folks. And so we're talking about clinical trials in part genetic testing And I like what Dr. Adams Campbell said, precision medicine. And that's really about how we can improve those outcomes. And so we've kind of talked about those terms that we hear all the time, health equity and inclusion and all that other stuff. But what really, I think, I love what you said, Dr. Adams Campbell, is about precision medicine and about improving outcomes. And by improving outcomes for Black and brown folks, as Dr. Jichi pointed out, it's going to improve outcomes for everybody, for everyone. So this is not just a specific talking about, but we understand that Black and brown folks have, a gap in terms of life expectancy, disproportionate illnesses that are impacting our community, and then all those social determinants of health, those, like I call them, the 4 dirty words of healthcare, called the social determinants of health, that are disproportionately impacting our communities. And so that's what we're talking about. And so what are some of those benefits? So if somebody's watching this program and we're trying to convince them to participate, and I put in the comment section, you can go to clinicaltrials.gov and find a list of clinical trials that are going on right now. What are some of the benefits for Black people to be involved? What would you say to somebody to say, hey, you should try to find a clinical trial to participate in, whether it's a medical trial or treatment trial or whatever? Why should more Black people get involved?
So piggybacking on what Dr. Adams Campbell spoke about with precision medicine, there's another aspect that actually Dr. Fauci has been calling for, and that is science implementation. The average time that it takes between a discovery that shows that X medication or X intervention is going to have better outcomes and life expectancy and better health and well-being, there's about a 10-year gap. So one of the benefits of participating in a clinical trial is that, guess what? You'll have the standard of treatment that maybe your doctor or your clinician isn't even giving you, right? Which I think is really key. I mean, if we look at people, let's say with diabetes or with heart disease, how many of them are getting all of the medications and all the treatments that have been shown to improve life expectancy and health and well-being? So to me, that's another aspect of all of this. And I would also say this, when a person is involved, it's not just the one person, it's the family, it's the community. So they are being cared for holistically, but also people then get educated. And then there could be the benefits for family members of like, oh my goodness, I didn't know that I had such and such a gene because that was tested for when my, family member, loved one was in a clinical trial.
I just want to add on to the importance of standard of care. I remember interacting with people that when I was trying to get clinicians to push towards them participating in clinical trials, and this makes sense. We understand it's not just the patients, it's the providers. Every provider is not engaged in clinical trial, nor do they want to be involved in clinical trials. But the academics continues. Everybody should be lifelong learners. We have to be. So, for example, the aspirin. Aspirin wasn't invented to save the heart. Aspirin was invented for pain. And what was the use now? An aspirin a day, even though that might be going away, but an aspirin a day for people at high risk, certain age, to prevent heart attacks or strokes. So there are really good reasons, benefits out of clinical trials. And also, I think that it is so important that we educate the providers that stay up with the data, offer the best treatment that's out there. And another little tidbit, when people say no to clinical trials and they have cancer, you're still going to get treated for cancer. You're just not on the clinical trial. And I want you to really understand that. You are going to be given probably the exact same medicine that you turned down for the clinical trial. And you probably don't even know why you turned down the clinical trial. You just turned it down. But then you say, but I got to get my treatment for cancer. So I'm going to get the same drugs, and not understanding that you could participate in your data being used to help promote the betterment of health, but also your attention, the care that you will get will be so much more in tune. Not saying doctors that don't use clinical trials don't reach out to their patients. I'm just saying It's different. So when you turn down a clinical trial, make certain you understand why. 'Cause if you get an exact same drug, say drug A is given first and then drug B, another clinical trial, drug B might be given first and then drug A. There's some simple rearrangements that are done at times. So I just want to know when people say no, and if I say, why do you turn it down? They really don't have an answer, but ingrained in their mind is we should say no. And
It may be something just as simple as the term clinical trials, right? Because when you hear that,
Mhm.
what can invoke in somebody's head is experimentation, right? And that
Mhm.
could be, and I'm not saying that that's right. I'm just saying that, like, when you hear clinical trials, you think about experimentation. Because even in the video that I played, they were talking about, oh, they tested on rats, and so we think about those on rodents before they even move it to people when they're developing a new
well,
drug.
that's a good thing. And that's a good thing that we don't test something that could be very lethal on a human being first.
Right,
And I
right.
think that people really get educated. I mean, I would love, maybe Dr. Gigi and I'll talk about this later. I would love to work towards a big clinical trial education program so we can educate physicians, fellows, and patients and the community residents what a clinical trial is so that we can get away from the negative connotation and put it in its right place. This is a science, and everything that you do, whether you put on makeup or you take a bath and use soap, it was all developed with some type of science. So we need
Mhm.
Mhm.
to get people into the science, from a
Mhm.
lay perspective or from a technical perspective based on where the person is. But I just think we need to stop making clinical trials the bad word
Right.
and get people engaged.
Yeah, and if I could add that one of the best places to have education, because I think the faith-based community, especially during COVID, has stepped up, from Choose Healthy Life to
Mhm.
individual churches.
Mhm.
For example, here in Washington, D.C., Temple of Praise is now offering classes on site from the University of the District of Columbia. So these are opportunities to bring education in the hug, if you will,
Mhm.
of the community by people who are trusted. So people can also ask their questions freely and to find out what those details are. But Dr. Adams Campbell, you mentioned the order of drugs being given for cancer. I remember with my breast cancer, I had my I had my surgery first,
Yes, yep.
and then I had my chemotherapy. And then this time around, 17 years later, when I had my kidney cancer, even though the surgeon wanted to remove my kidney first, my oncologist, my cancer specialist said, no, the research says that you have better outcomes if you get the chemo first. And guess what? So that comes from research, that comes from
Right.
clinical trials.
Right.
So my life expectancy was increased because my oncologist was familiar first with standard of care, and then after I got treated, he was the one that referred me to the NIH because he knew that there was a clinical trial for my type of actually rare cancer.
Yep.
Wow.
So, I mean, I don't want to make this sound like it's, oh, well, what are you going to do with this information? We benefit directly. We benefit directly.
Well, there's a couple of great comments I want to highlight that are coming through from the people watching. So I want to say first, thank you all for watching and for putting your comments. There's one here that she's pointing out that there's a current precision medicine initiative called All of Us, and I am familiar with that program. I think we've had them here on Black Doctor.
Yes.
And you can enroll at allofus.nih.gov, and that basically all that does is they get your medical records, I believe, and then they just kind of cross-reference it, and they have a database. And so they collect all that data and they say, here's how, and they look at your records and they put all the Black people that may have had this particular medication and taken this particular medication and how their outcomes were. And they just compile all this data, and there's also clinical trials as part of it. So it's a really kind of big organization, and you can participate as much as you want to. So it's not just you're in or out. You can participate at different levels. And Layla, I hope that's your name. I'm pronouncing it correctly. If I'm wrong, put it in the chat room if I'm wrong. But I think this is what I learned from, because I conducted that Facebook Live. And so check out all of us at NIH.gov. They are wonderful organizations, so check them out. And then there's this other one that is a great comment. Davida, thank you so much. She said, I'm so committed to this conversation as a nurse practitioner in Philly. Health inequities are a major issue, and I am a staunch advocate. So I just want to say thank you for joining us today, and thank you for being an advocate, because we need more people out there that are working on the behalf of everyone. So
Can I
just say,
we both had a
I was just gonna say something, because I don't want either one of our comments to be misconstrued about diversity, equity, and inclusion. I just don't like the slogan without any action. It's basically, if you're gonna talk the talk, walk the walk.
Right.
And I was going to say about advocates, key, instrumental. Why do we have so much money behind breast cancer? Because there were so many advocates. We need to do this across many other diseases. Black men die at an alarming rate. Prostate cancer. We talk about breast cancer, but there are a heart disease. All these things. We don't have enough advocates. We've got to get people involved. And I do think the faith-based approach is right on point, and we do reach out to the faith-based group and have community advisory council and have members from that. So I really get that, but the advocates are so important.
Yeah.
And if people want to volunteer, be advocates, it's well worth it. And have advocates at the table when we design studies, so that you can put in your comments and we can get real feedback from people that have gone through these diseases. Oh, I can't come to your office 20 times a month. You have to make things practical. So I think advocates are so needed and so vital. And even NIH and the federal agencies recognize that, because now they make certain that an advocate sits on the review committees for federally funded grants. And I think that's so important. So hats off to all the advocates. It's definitely needed.
Well, and also because Ms. Graham is a nurse practitioner, I hope you noticed, Ms. Graham, that I didn't say doctors, I always said clinicians. I mean, people, whether nurse practitioners or nurses or physician's assistants, but they are much better advocates. I mean, we're both physicians, but
not me.
Truly.
I'm only PhD.
Oh, PhD. Well, but I mean to say that physicians, I mean, we get a lot of the credit, but the reality is the best advocates for patients and the ones that really get the idea of families are really the nurses, and from that same tradition, the nurse practitioners, and of course, pediatricians. They're the best.
And also navigators. We utilize navigators to get people from point A to B. We might think point A to B is very easy to do. For many people, point A to B is like driving from here to Europe or somewhere. It's not easy. So navigators play a critical role, whether they're lay community advocates, whether navigators or nurse navigators, whatever they are, they play a major role in seeing the success in the outcomes.
Absolutely. So I could talk to you both all day long. Unfortunately, we've got more to do here today for our Minority Health Summit. This has been this is the fourth program, third or fourth. I can't. We talked about colorectal cancer earlier. We talked about diabetes. This is our third program, and we're talking about clinical trials and genetic testing and how we can be more involved. I love all of the points that were made today, and I think it's important for all of us to go check it out. So clinicaltrials.gov, all of us, that's why they named it the All of Us program. Go find out about how you can become involved, because you cannot complain if you're not engaged. And so that's the one thing, is that you got to engage. The more we engage, the better our outcomes can be. And so I want to say thank you so much, Dr. Adams Campbell, so much. This has been a wonderful conversation. Dr. Gigi, as always, it's a pleasure to see and speak with you. And thank you to all the audience. Y'all were wonderful. I mean, nurse practitioners stepping up, with people just really speaking life into what we're trying to do here today. So we've got more to do. We've got 2 more programs. So coming up at the top of the hour, we're going to be talking about healthy eating to prolong your life. So, and that's something that all of us can talk about, is how we need to eat better, eat better, and that will definitely help prolong our lives. So I will see you all at the top of the hour. Dr. Adams Campbell, we can have you back anytime you want to come back. Just send us a message and we will get you on to talk about this, because we're going to have some more programs coming up about clinical trials. This is not going away, because this is a key component, not the component, but a key component for improving our health outcomes. So
thanks for the invitation.
you're welcome.
Thank you. Bye-bye.
Bye.